Well, hello everybody. We need to talk about gastrointestinal drugs. Follow along with the PowerPoint slide. You have your notes as well, and your book. All right, so acid-related pathology. To start, the stomach secretes several things that we need to talk about. Hydrochloric acid, obviously. Acid helps to aid in the digestion of foods, but it's also important to understand that the acid in the stomach makes a very hostile environment, and so it makes it very difficult for pathogens, to cause infections. When I eat food and drink coffee and whatever else I'm doing, whatever I put in my mouth is not sterile. So there's bacteria, there's microorganisms, there's fungus in those things. And if I didn't have a hostile environment to kill those things as well, I could very easily get infections. So hydrochloric acid both aids in digestion and helps to protect my body from microorganisms. The bicarb we've talked about before. It's an alkaline, it's a base. It helps to protect the lining of my stomach from the hyperacidity that's created by the hydrochloric acid. So it serves as a protective factor. The pepsinogen, again, we've mentioned this before. Pepsinogen is just a precursor to pepsin, which is the enzyme that's needed for protein digestion. That's secreted right in the stomach. The intrinsic factor, we've mentioned before, comes the parietal cells, and that's necessary for my GI system in order to be able to absorb vitamin B12, which I need to make red blood cells so that I don't become anemic. So that's intrinsic factor. Mucus, we talked about before when we did adrenal glands. The mucus serves as a protective barrier, again, to line the mucous membranes of my digestive tract so that it doesn't get burned from the hydrochloric acid, doesn't get eaten away from the pepsin. So it just serves as a protective factor. And prostaglandins are anti-inflammatory. They have anti-inflammatory functions. As far as the glands in the stomach, basically named for the areas from which they're derived. The cardiac is up near the gastroesophageal sphincter, also called the cardiac sphincter, called that because it's near the heart. So we have the cardiac area of the stomach. Certain glands are located there. We have the pyloric area of the stomach, again noted for the pylorus, the lower end of the stomach, and then the gastric, which is located kind of near the fundus of the stomach. The cells of the gastric gland are the largest in number, primary importance when discussing acid control. So that's really kind of where we're focusing on. As far as cells of the gastric glands, you've got the parietal cells, the chief cells, the mucus cells. These are the three that really need to kind of stay in balance in order for everything to remain functioning the way it's supposed to. The parietal cells produce and secrete the hydrochloric acid. That production is in response to histamine, acetylcholine, and gastrin. That's important to understand because obviously if you can think about it in terms of restoring balance and health to the GI system, if we could counteract histamine receptors, acetylcholine, gastrin, then we could maybe limit the amount of hydrochloric acid that's produced to create a less acid environment. So that's kind of important to understand. And you've got the graphic there that shows you the receptors and everything. The histamine receptors, again, histamine stimulates CAMP, which we've talked about before, which stimulates the proton pump to transport hydrogen ions for the production of hydrochloric acid. So there's that whole complex, there's that whole sequence that could be interrupted, again, to try to limit the amount of acid that's produced to restore health. You also have the acetylcholine and the gastrin receptors. What they do is they stimulate calcium ions, which in turn stimulate the proton pump, again, to transport the hydrogen ions for the production of hydrochloric acid. Anticholinergic drugs like atropine block acetylcholine receptors, which would decrease the production of hydrochloric acid. However, we don't usually use anticholinergic drugs nowadays to treat GI disorders, although they do have some function there. The chief cells, which their main role is to secrete pepsinogen, which is, again, the precursor to pepsin. Pepsin is responsible for breaking down proteins. The pepsinogen becomes activated when it's exposed to the acid and then becomes pepsin, which breaks down the protein. And then mucus, like we talked about before, the mucus secreting cells line the surface of the gastric mucosa, and what they do is they produce a protective coat, a mucus coat that protects the lining of the GI tract to protect it from the effects of the hydrochloric acid, from the pepsin, and all of that. And then we've also got the endocrine system that plays a factor in there. The enterochromaffin basically secrete histamine in response to gastrin. Histamine, gastrin are the primary positive regulators of hydrochloric acid secretion from the parietal cells. Whenever you have a hypergastremic state, it may result in cancerous changes. That's important to understand. Usually it results in those enterochromaffin, or originates in those enterochromaffin cells. Can lead to erosions, Barrett's esophagus. But something that you'll talk about again in third level is whenever you've got tissue, like the lining of the GI tract, that is repeatedly insulted over time. It's repeatedly exposed to inflammatory processes and injury and insult. It has an increased likelihood of becoming cancerous as it reproduces. And so if we have an imbalance between these cells, like we talked about, the parietal, the chief, the mucus, and we end up with too much pepsin, we end up with too much gastric acid, we end up with not enough mucus protecting, we end up with not enough bicarb protecting the lining of the GI tract, then what can happen is the mucosa of the GI tract gets insulted over time, inflamed over time, and as a result, over time, it's more likely to become cancerous and lead to other problems. So again, we want to try to keep those things in balance so that doesn't occur down the line. As far as hydrochloric acid, again, secreted by the parietal cells, maintains a stomach pH anywhere from 1 to 4, but typically about 1 to 2. It's a very acidic environment. We've talked about that before also, whenever we did the autonomic nervous system. Already talked about that second bullet, or that third bullet point there. The secretion of acid is stimulated whenever I eat large fatty meals or emotional stress. And again, we talked about that with the adrenergic system. As far as acid-related disorders, peptic ulcer disease, basically ulcers in the GI system. It could be gastric or duodenal, where basically, again, we've got an imbalance of those caustic factors and the protective factors, where those caustic, those irritating factors are able to, over time, erode and cause ulcerations into the lining of the GI tract. That's what peptic ulcer disease is. H. pylori, Helicobacteria pylori, is basically a bacterium. It's a spiral shape in nature, and so what it does is it actually spirals, it burrows down into the lining of the mucosa of the GI tract, which makes it very, very difficult to treat. It's important to talk about H. pylori because the H. pylori is actually found in about 90% of patients who have duodenal ulcers, 70% of those with gastric ulcers. So you can see there's a high prevalence of H. pylori in patients who have peptic ulcer disease. However, it's not the only factor. It's present in people who don't have peptic ulcer disease as well. But it's important to understand that. As far as first-line treatment to treat patients who have peptic ulcer disease, usually is to find a way to knock out the H. pylori. Usually involves anywhere from a 10-day to a 2-week course of a PPI, a proton pump inhibitor, some of the things we're going to be talking about in just a little while, as well as the antibiotics that we mentioned last week, Biaxin, which is clarithromycin, or amoxicillin, Flagyl, or it can be a combination of a PPI, which we'll talk about later, Pepto-Bismol, which is bismuth, some salicylate, which is a form of aspirin actually, and again the antibiotics tetracycline or Flagyl, metronidazole. So they need to do something to wipe out the H. pylori in order to help treat the peptic ulcer disease. And they usually order those antibiotics along with the PPI. And then the third one on there is the stress-related mucosal damage, where basically GI lesions, set in patients who have a lot of stress, which is why we talk about decreasing stress in people's lives. Being in the hospital is a stressful occurrence for patients. That's why most patients who are admitted to the hospital, they're ordered a proton pump inhibitor, a PPI, to try to limit the amount of acid that they're producing as a result of the stress of being in the hospital, worrying about their health and being away from their support system and how am I going to pay for this and I'm missing work for this. That's a stressful experience. And so most patients who are admitted as an inpatient, they end up having a PPI ordered to counteract the stress that we expect that they're going to encounter as a result of being in the hospital. Another thing to talk about here with the stress-related mucosal damage is educating the patient about some of the lifestyle changes that might be necessary to avoid some of the symptoms, limiting their stress in their life, finding coping mechanisms, using their support systems, altering their diet, changing their diet. So there are a lot of lifestyle changes that we could educate our patients about also to try to help with some of these acid-related diseases. As for the types of acid-controlling drugs, antacid, something to counteract the acid, to bring the acid level down to restore the balance. We could give a histamine antagonist. Again, histamine is responsible for the production of the hydrochloric acid. So we could find something to antagonize the histamine to bring down the amount of acid that's being produced. Or a proton pump inhibitor. And again, it's the proton pump that transports those hydrogen ions that allows the hydrochloric acid to be produced. So if we could find a way to inhibit that pump, we could limit the amount of acid that's being produced, again, to try to restore the balance between the caustic factors, the irritating factors, and the protective factors to keep things in balance the way it was designed to function. So the first one we're going to talk about will be antacids. Antacids are basically alkaline basic compounds that are used to neutralize the stomach acid to restore the balance of that environment in the stomach. Usually they're salts of minerals like aluminum, magnesium, calcium, sodium. Very frequently the antacid preparations also might contain an anti-gas, an anti-flatulent component, which is usually simethicone, which we'll talk about later as well. There's lots of different formulations. Most of these are available over the counter. People take these over the counter medicines thinking that they're safe. But again, like we've talked about before, even over the counter medicines do have some risk that are inherent to them. So it's important to understand that. Many of the aluminum and the calcium-based formulations also contain magnesium because, as we mentioned earlier, whenever we talked about some of the electrolytes, calcium is considered as a neuromuscular relaxant. So the more calcium I have, the more my muscles become relaxed, including the smooth muscles that are responsible for peristalsis, to move things through my GI system. So if I'm taking a lot of calcium-related antacids, my peristalsis is going to slow down. And the result is I could become constipated, which is really the number one side effect of taking calcium supplements. So to counteract that, a lot of times they will mix magnesium in some of the antacids as well, because magnesium actually stimulates the smooth muscles of the GI tract. And so by stimulating the smooth muscles of the GI tract, they're stimulating peristalsis, and that helps to counteract the slow peristalsis that results from taking all the calcium that's in the antacids. So they mix magnesium with those calcium antacids sometimes. A couple other things to keep in mind: that the antacids that contain magnesium really should be avoided in patients who have renal failure, because the kidneys can't regulate that magnesium as well because of the kidney disease, the nephropathy, and so as a result the patient could end up having a very high magnesium count. And also, one thing that we did mention earlier, and you've talked about this in level 1 as well, is whenever you take lots of calcium, the kidneys are responsible for filtering out all that calcium that's absorbed into the bloodstream, and then you have all these large calcium deposits forming in the kidney, which leads to things like kidney stones. So it's important to keep that in mind, the increased likelihood of forming kidney stones whenever somebody's taking lots and lots and lots of calcium supplements or lots and lots of calcium antacids. Sodium bicarb is another mineral formulation that can be used as antacids. It's highly soluble, has a quick onset, but a short duration of action. Another thing to keep in mind with sodium bicarb is it really lets the person become at risk for forming metabolic alkalosis, which we'll talk about later. As far as mechanism of action of antacids, keep in mind that antacids, they counteract acids. They do not prevent the production of acid. All they do is they neutralize the acid that's already there. In addition, they do help to stimulate the secretion of the mucus, which again serves as a protective barrier against the hydrochloric acid to protect the stomach. Very similar, they also help to stimulate the secretion of the bicarb, which is an alkaline. It's a base to counteract the effects of the acid that's already there. They help to buffer the acid that's there. And they also stimulate the secretion of the prostaglandins, which help to prevent the activation of the proton pump to help limit further production of acid. As far as effects, again, what they do is they neutralize acids. So they help to raise the gastric pH, to bring it up. And actually, as you see in the slide there, raising the gastric pH just by 1 point helps to actually neutralize about 90% of the gastric acid that's in the stomach, which again makes the stomach a lot less of a hostile environment, so it doesn't irritate the lining of the stomach quite so much. And as a result of reducing the acidity, it reduces the pain that results from the overproduction of the acid. As far as indications, obviously, relief of the symptoms of peptic ulcer disease, gastric ulcers, the hyperacidity, and then heartburn, which is just the reflux of the acid getting up into the esophagus and burning the esophagus. Contraindications, again, severe renal failure, because the person's kidneys may not be able to manage the high levels of the electrolytes, and so toxic ranges of the electrolytes could end up resulting. If the person has electrolyte disturbances to begin with, again, we want to limit the amount of further electrolytes that they're taking. They could become toxic. If there's a GI obstruction, that's also a contraindication for antacids. Again, some of the antacids may actually stimulate GI motility, and if the person has a obstruction, which means that fecal material cannot pass through the digestive tract, it's obstructed, it's not moving. You don't want to give something that's going to increase the motility of the GI tract, which would then make the problems of the obstruction even worse. Could lead to a toxic megacolon, which is potentially life-threatening. So that's important to understand. As far as antacids, again, many of these are available over the counter in several different formulations: capsules, tablets, powders, chewable tablets, suspensions, which means a liquid, effervescent granules, which means they put them in liquid and it dissolves, it effervesces, makes a fizzy drink that they drink. As far as aluminum salts, again, kind of mentioned this earlier, aluminum has a constipating effect, so they usually add magnesium into the aluminum salts. This is your Maalox, your Mylanta, where they have aluminum and magnesium mixed together. But again, you have to be careful with your renal patients taking Maalox, taking Mylanta. Those kidneys cannot regulate the magnesium, and it can be toxic for the person. As far as magnesium salts, this is basically your Gaviscon, your milk of magnesia, which can be used as both an antacid and as a medication for constipation, which we'll talk about later, because again, magnesium stimulates the gastric smooth muscles. So it really depends on how much the person is taking. And then again, the magnesium salts are mixed a lot of times with either aluminum or magnesium to counteract the constipating effects of those electrolytes that are used for antacids. But again, magnesium salts, dangerous with renal failure, so be careful of that. As far as calcium salts, again, a lot of people think that the calcium Antacids are safe. Calcium carbonate in particular is Tums. A lot of people take Tums simply as an extra dietary source of calcium. But again, it can be very constipating. It can lead to kidney stones. It can be toxic in patients who have renal disease. So again, like we've talked about so many times this semester, doesn't necessarily automatically mean it's completely safe. So we need to know what the person is taking. Getting a good, accurate history when the person comes in complaining of having heartburn, stomach upset, a lot of acid complaints in their stomach. What are you taking? We need to know what they're taking, because it could actually be leading to other problems that the person's experiencing. Another thing to keep in mind with calcium salts, they have a very long duration of action in the stomach. And so when the person stops taking them, there can be a rebound and an increase in how much stomach acid the person begins to secrete or produce whenever he stops taking the calcium antacids. And as a result, he can have this rebound hyperacidity, where now all of a sudden he's got this excess amount of acid in his stomach. Again, sodium bicarb, highly soluble, it buffers the acidic properties of the hydrochloric acid, has a quick onset, short duration. However, put a star next to that next one, it may cause metabolic alkalosis, which could be very dangerous. And again, the sodium content that's present in there could cause problems in patients who have renal failure or heart failure or hypertension, because the sodium encourages the patient's body and kidneys to reabsorb and hold on to more fluid, which would expand the intravascular space, which would raise the hydrostatic pressure, which could be a problem for somebody with heart failure, and their heart can't pump that amount of fluid and it starts to back up and lead to the problems of heart failure, which we've talked about a couple weeks ago, and same thing with hypertension. So sodium bicarb has to be used cautiously in patients who have cardiac conditions like heart failure, hypertension, renal conditions, and then again, always be aware of metabolic alkalosis. As far as adverse effects, again, overuse could lead to metabolic alkalosis because we're neutralizing too much of the body's acid, which could swing the balance too far in the other direction and cause a metabolic alkalosis. Aluminum, calcium could cause constipation. Magnesium, too much, could cause diarrhea. The calcium can lead to kidney stones when the person stops taking the calcium. It could lead to a rebound hyperacidity. All those things that we've talked about. Another thing to keep in mind, which we should probably talk about with this slide, is long-term use of antacids could mask the signs and symptoms of some underlying condition that's actually leading to the person having these signs and symptoms to begin with. He's got all this stomach upset, all this stomach pain, all this abdominal discomfort. He thinks he's having heartburn. He thinks he's having digestive problems. So he takes antacids on a daily basis, several times a day. And the problem is this long-term antacid use is actually masking a more serious underlying condition like a bleeding ulcer, malignancy. It could be something else. So again, accurate history, a detailed history is very important to try to catch any of those problems that might actually be going on. As far as drug interactions, we want to make sure that the person taking antacids really does space his administration of the antacids about 1 to 2 hours with any other medication that he's taking, because it's going to affect the absorption of any other drugs that he does take. So we want to make sure that he understands to take his antacid, about 1 to 2 hours outside of the time that he takes any of his other medications. A couple other things to talk about is adsorption, adsorption of other drugs to antacids. What can happen is the antacid could actually bind to the other medication that he's taking, and it could reduce the ability of that drug to be absorbed to begin with. It actually chelates, it binds to that drug. There are times when we actually want chelation, we want binding to occur so that things can't be absorbed. Like when there's an overdose situation, we want to give an adsorbing substance like activated charcoal, that actually binds to that medication that the person overdosed on, so it cannot be absorbed. Well, the problem is antacids could adsorb to medications the client's taking and prevent those medications from being absorbed. So again, you want to make sure that you space those medications out by at least 1 to 2 hours. Many drugs are either weak acids, weak bases, so changing the pH in the stomach will affect the absorption and the elimination of drugs. So having an increased stomach pH could alter the absorption of drugs. There would be increased absorption with basic drugs. There would be a decreased absorption of acidic drugs. Likewise, changing the pH in the GI tract will change how those medications are eliminated as well. So increasing the urinary pH could increase the excretion of acidic drugs that are excreted and eliminated through the kidneys, and increasing urinary pH could decrease the excretion of alkaline drugs, of basic drugs. For example, absorption of the fluoxetins, the quinolones, are reduced by about 50% when they're taken with antacids, which is why we want to space the administration out by 1 to 2 hours, so we don't have those interactions. As far as antacids and antiflatulence, again, flatulence is gas. These are medications that are used to relieve the painful symptoms that are associated with gas. Primarily, we talk about simethicone, which we've talked about before, I mentioned earlier. What simethicone does, it's available PO orally only. Simethicone really has no listed adverse effects, drug interactions, doesn't really have any pharmacokinetic parameters listed to it. All the simethicone does is it alters the elasticity of the mucus-coated gas bubbles, which allow the gas bubbles to pop. They break down. And so as a result, the patient doesn't have these big gas bubbles, so it reduces the pain, and the person's able to eliminate them otherwise. And again, simethicone very frequently is added to a lot of the antacids to limit the amount of gas that's produced. All right, as far as antacids, the next, acid controlling drugs, the next category to talk about would be the histamine receptor antagonists, the H2 receptor antagonists. These are your tadines. If you look at the generics that are listed there on the slide, cimetidine, nizatidine, famotidine, ranitidine, these are the tadines. And what they do is they reduce the amount of acid that's actually secreted, produced. All of these medications that are listed are all available over the counter in lower dosage forms than what the prescription would be, but there's really little difference between these drugs, the Tagamet, the Pepcid, the Zantac, but these are all available over the counter, limiting the amount of acid that's produced. They competitively block those histamine receptors, which are responsible for producing the acid in the parietal cells. We talked about those before. So as a result, it increases the pH of the stomach. It makes it a less hostile environment, so that the increased acid isn't causing erosions and irritations and inflammation to the lining of the stomach. As a result, it relieves many of the symptoms that the person is experiencing from having that hyperacidity in his GI tract. Indications, again, GERD, the reflux of the acid up into the esophagus, peptic ulcer, the erosive esophagitis, which is just that acid getting up into the esophagus over time can start to erode the lining of the esophagus and cause problems up there as well, erosions up there. It can be adjunct therapy to control some GI bleeding that's going on, and then Zollinger-Ellison syndrome, which again is just basically a gastric hypersecretory condition. The person's secreting too much stomach acid. As far as adverse effects, overall there really are very few. There can be some central nervous system effects, especially in the elderly patients, underlying elderly patients. They're uncommon by and large, but the risk is there, so it's important to understand that. As far as Tagamet, cimetidine, there is also a risk there of impotence in males and gynecomastia, because what Tagamet specifically can do is inhibit the estradiol metabolism. It actually displaces testosterone from the androgen binding sites, and so it can lead to this feminization in males. Again, if it's taken on a long-term basis, if the person's taking Tagamet over the counter on a long-term basis, it can lead to some of these problems, which again is why it's important to get a detailed, accurate history so you can figure out what's going on. Those side effects are reversible when the person stops taking the Tagamet, and so again the testosterone can then get to the androgen sites, and it is reversible. Also, the ranitidine, the famotidine, the Zantac, the Pepsid, those things also, there is a likelihood, a small likelihood of thrombocytopenia, a low platelet count. But again, the risk is there, so it's worth noting. If these medications are given intravenously, which they are available intravenously, it's important to monitor the blood pressure during IV infusion. Too rapid of an IV infusion of these medications can lead to hypotension. As far as drug interactions, the cimetidine, Tagamet, again, has more of the adverse effects than do the others, especially in older adults. It can lead to inhibited oxidation of many other drugs and lead to increased drug levels, which can lead to toxicity. All of the histamine antagonists may inhibit the absorption of drugs that require an acidic environment in the GI tract for absorption. We've mentioned that already earlier. Smoking has been shown to decrease the effectiveness of the histamine blockers. And so again, for optimal results, histamine receptor antagonists really should be taken 1 to 2 hours before other medications and outside of the parameters of taking antacids, which I mentioned just a minute ago. The next category are the PPIs, the proton pump inhibitors. You'll see these used very frequently, like I mentioned earlier. It's pretty routine practice now that hospitalized patients are routinely ordered proton pump inhibitors, unless it's contraindicated, to counteract the effects of stress in a hospitalized client, to minimize the amount of acid that he's producing, to limit the amount of GERD and peptic ulcer disease that may result of being hospitalized. Now these are our prazols. Again, if you look at the list of generics that are on the slide there, the omeprazole, the pantoprazole, these are really common. These are also available over the counter, Prevacid, Prilosec, Protonix, Nexium, but these are our prazols, proton pump inhibitors. Again, they work in the parietal cells by limiting that proton pump, the transportation of the hydrogen ions that are needed for the proton pump to release and produce the hydrochloric acid. So the proton pump inhibitors just inhibit that proton pump from producing and releasing the hydrochloric acid into the stomach. Okay, mechanism of action. Again, they irreversibly bind to hydrogen, potassium, the enzyme that's needed to make hydrochloric acid, to prevent the movement of those hydrogen ions from the parietal cells. Already mentioned that, and the result is there's a total blockage of hydrogen ion secretion from those parietal cells for approximately about 24 hours. It results in this state of achlorhydria, where basically all gastric acid secretion is temporarily blocked, about 90%, again, for about a period of 24 hours. But again, keep in mind that not only do you need the stomach acid to produce or to help with digestion, but you also need that stomach acid in order to create a hostile environment enough to prevent infection from setting in from whatever the person is taking. And so as a result, it could lead to increased bacterial growth, changes in the intestinal mucosa that could lead to secondary infections setting in. It actually could lead to changes in absorption of some of the electrolytes. It could lead to hip fractures, osteoporosis, but it does not necessarily affect food absorption. As far as indications, these are available, they're all available orally and enterally. Some of them are available intravenously. As far as the enteral forms, which means instilling it directly into the stomach or the lower GI tract, which means either an NG tube, a PEG tube, a gastric tube. Keep in mind that the size of the granules could become a problem. If you're trying to put these medications through an NG tube, through a PEG tube, they could clog the tube. So it's important to keep that in mind. Talk to the pharmacy, make sure that they're safe to go through a PEG tube. There could be other formulations of these medications that could be ordered by the doctor if the person gets an NG tube inserted. Not all these medications will fit through the PEG tube. Not all these medications can be grinded up to put through a PEG tube. So talk to the doctor to see if we can switch. You might need to talk to the pharmacist to see which ones are available or best to go through the PEG tube or the NG tube, and then talk to the doctor and specifically request those medications instead. As far as indications there, again, the same list of things that we talked about before. It is considered first-line treatment for all of these medications. They're used very frequently, like I mentioned earlier. Also, these are used very frequently for the long-term use of healing of erosive esophagitis and bleeding ulcers when the person has a hypersecretion of hydrochloric acid. These are used for long-term management of those conditions as well. And like I mentioned earlier, the proton pump inhibitors are also part of the treatment plan of patients who have peptic ulcer disease as a result of H. pylori. They're given with an antibiotic, again, either clarithromycin, amoxicillin, metronidazole, but the PPIs are given with those antibiotics to treat the H. pylori that's resulting in the peptic ulcer disease. As far as adverse effects, the PPIs are generally very well tolerated. There is a predisposition in the GI tract to allowing opportunistic infections to set in, like C. diff, like I already mentioned, because you need that stomach acid to make a hostile environment so infections can't set in. So if we're neutralizing too much of that stomach acid, if we're limiting the amount of stomach acid that's being produced, the problem is opportunistic infections like C. diff could set in. Like I already mentioned, absorption of minerals could be a problem. So osteoporosis could set in, which could lead to an increased risk of fractures. Pneumonia could be another problem as well as depletion of magnesium because of the limited magnesium absorption. As far as drug interactions, with Coumadin and warfarin, there could be an increased chance of bleeding. Like I already mentioned, a decreased absorption of some drugs, decreased absorption of some minerals. With Plavix, clopidogrel, there's an increased risk of death, especially with acute coronary syndrome. And food may decrease the absorption of PPIs. So one of the teaching components of the PPIs is the person really should take the PPI on an empty stomach about an hour before he eats any meals, about an hour before he takes any of his medications. And also there is an increased risk of esophageal erosions, esophagitis. So as a result, the person should limit the amount of food that he's taking and everything, because you don't want him to over distend his stomach, which could lead to reflux and get that up in his stomach and cause an erosion in the esophagus. As far as some miscellaneous acid controlling drugs that we'll talk about, Carafate, Cytotec, which we've talked about much earlier this semester, and simethicone, Mylicon, which I already mentioned just earlier this afternoon. The first one we'll talk about is Carafate. It is a cytoprotective drug. Basically, it's used for the long-term treatment of peptic ulcer disease. It serves as a mucosal protectant for active stress ulcers. Basically what it does is it's attracted to and it binds directly to the base of erosions. So it only coats and protects those areas where there are erosions present. It doesn't necessarily coat and protect the entire stomach. It only forms a protective barrier over the areas that are actually eroded. It acts locally. It doesn't act systemically. It's not absorbed. It only binds and it is attracted to those areas where there are erosions. Carafate does dissolve into aluminum and sulfate, which is important to understand. That aluminum stimulates the secretion of mucus and bicarb, which we talked about before. The increased mucus helps to serve as a protective barrier of the GI tract, and the bicarb helps to neutralize and counteract some of the acid that's there. So the carafate that dissolves down into the aluminum, that's important. And then carafate also dissolves down into sulfate, which again binds to the tissue proteins at the base of the ulcers to serve as a protective barrier right at this site of erosion, right at the ulcer itself. And what that collectively does is it protects that area from the pepsin, which again, pepsin is the enzyme that you have present in your stomach, which is responsible for breaking down protein. And let's face it, your stomach lining is made of protein, and so you don't want the pepsin to act directly on the lining of your stomach. It would eat it away, it would break it down. Again, there's very little absorption. It acts locally, not systemically. As far as adverse effects, it can lead to constipation, it can lead to nausea and dry mouth. When somebody's taking carafate to observe for the signs of adverse effects, it's important to assess for abdominal distension. It's important to assess for abdominal rigidity. This, again, could be signs of toxic megacolon, because what can happen is the peristalsis slows down to the point that it backs up so much that it leads to basically a toxic state, a very dangerous, life-threatening state. So assess for abdominal distension and rigidity when the person is taking carafate. Again, carafate will impair the absorption of drugs. So take these drugs, take carafate about 2 hours separated from any other drug that he might be on. Carafate binds with phosphate, so it might actually be used in chronic renal failure to reduce the phosphate levels. So you might see it being given with for patients who have chronic kidney disease, renal insufficiency, any kidney problems. Cytotec we talked about earlier this semester when we talked about NSAIDs. It's a prostaglandin E analog, which again have a cytoprotective activity. We mentioned them earlier when we talked about the NSAIDs. You'll see them given very frequently with NSAIDs. I have it bolded and in red letters on the slide for you. Cytotec is used for prevention of NSAID-induced gastric ulcers, which really is about the second leading cause of peptic ulcer disease. You know, people overusing NSAIDs can lead to erosions and ulcers in the stomach. So Cytotec, if the person has to take NSAIDs on a long-term basis, the doctor may prescribe Cytotec to help protect his GI mucosa from the effects of the NSAIDs that he's on a long-term basis. Doses that are therapeutic enough to actually treat duodenal ulcers often produce things like abdominal cramps, diarrhea. They're not well tolerated by the patient. So as a result, they're really not effective as treatment for peptic ulcers. Most commonly PPIs and histamine blockers are used instead, even though Cytotec could theoretically be used in the treatment of peptic ulcer disease by helping to protect the gastric mucosa by increasing the production of the mucus, the bicarb. But again, if the person took these in a high enough dose to get the effects of those, they're just not well tolerated because of the cramps, the diarrhea. It's also important to understand and know that Cytotec is a pregnancy X category drug. Do not take Cytotec with pregnancy. Methicone Talked about this earlier, an anti-gas drug, anti-flatulent drug. All it does is it alters the elasticity of the mucus coating of the gas bubbles to allow them to lyse, to break down, so that they break down into smaller gas bubbles, and the person then can expel them more easily. As far as nursing implications with the antacids, as always, assess for allergies, pre-existing conditions, especially things like fluid imbalances, electrolyte imbalances, renal disease, GI obstruction, especially if the person is taking anything with magnesium that would increase GI motility, pregnancy, especially for things like side attack, patients who have any cardiac history like heart failure, hypertension, they should not take any of the antacids that have high sodium contents, like we talked about, because then the person is going to expand their intravascular space, which would increase the hydrostatic pressure, which could make high blood pressure, hypertension even worse, and it could make heart failure worse. Most of the medications should be administered about 1 to 2 hours, separated from an antacid, like we mentioned several times. Long-term self-medication with antacids could mask the symptoms of a more serious condition that's going on. So again, make sure you get a good, accurate history of what the person's symptoms are, how long ago they started, what they've been taking for it, what makes it better, what makes it worse, all those things. Make sure you're monitoring for any adverse effects, nausea, vomiting, abdominal pain, abdominal distension, diarrhea. Assess their bowel patterns, assess for any bowel pattern changes that they might be experiencing. Remember, with calcium-containing products, constipation is a very common side effect, adverse effect, which is why very frequently they add magnesium to calcium antacids. But a lot of people take Tums, which is calcium carbonate, and that actually could lead to constipation. And remember, when the person stops taking his calcium antacid, it could lead to a rebound hyperacidity where his body starts to produce more stomach acid as a result. And then notify the healthcare provider if the symptoms are not relieved. Specifically as far as H2 antagonists, again, long-term self-medication with antacids could mask the problem of more serious conditions. Use these in caution in patients who are elderly, confused, disoriented. We talked about that. Make sure you space out these medications with any other medications by about 1 to 2 hours. As far as the PPIs, assess for allergies, assess for liver disease, assess for swallowing function. Some of these medications, the size of them is actually pretty large, so make sure the person can actually swallow his capsules. Assess for a history of osteoporosis. Again, a person taking PPIs is at an increased risk of developing osteoporosis and fractures. So you want to know if the person has a history of osteoporosis, where the PPI would just compound that problem. Also, a history of gastrointestinal infections, because you're losing the antimicrobial protection from the acidic environment. So make sure that you're doing an assessment of those kind of conditions before giving the PPI. Not all of the PPIs are available in parenteral administration. So again, talk to the pharmacist to find out whether you can give this medication parenterally or not. If the medication is ordered to be given through an enteral tube, an NG tube, a PEG tube, make sure that the tube is large enough that the granules, that the crushed medication can actually get through the NG tube. And again, this may require a phone call to the pharmacist and find out whether that medication can be given through the tube, and then a subsequent follow-up phone call to the physician to get a more appropriate medication ordered that can go through the tube without clogging it. Okay. Next, we will talk about bowel disorder drugs. Basically, a lot of these medications do not have the classic pharmacokinetics as far as absorption and distribution and everything that we've talked about previously. There's your digestive system, which we've talked about before. And we'll talk about different conditions that affect different parts of the digestive tract. Diarrhea is the first condition we'll talk about. Diarrhea, I think we all understand what that is, abnormal passage of stools with increased frequency, increased fluidity, which again, if I'm losing more fluid through my digestive tract than what God designed, it can lead to problems like dehydration. As far as types of diarrhea, acute diarrhea is a sudden onset in a previously healthy person. It's usually self-limiting and it resolves without any further complications. And then chronic diarrhea is diarrhea that lasts for more than 3 to 4 weeks, which can lead to other problems, loss of appetite, nutritional deficits, nausea, vomiting, weight loss, chronic weakness, long-term chronic problems. As far as goals of diarrhea treatment, obviously stopping the stool frequency, helping to alleviate some of the abdominal cramps from the increased peristalsis of things passing through too quickly, trying to replenish and restore the balance for the fluid and electrolyte imbalances that result. Like we talked about when we talked about potassium specifically, remember, really the number one cause of low potassium levels is GI losses. So if the person has frequent chronic diarrhea, we're going to really watch that potassium level. He's at a really high risk of having hypokalemia. So another of the goals of diarrhea treatment is to watch that the electrolyte levels and specifically potassium to make sure that we're monitoring and treating for any hypokalemia. And then preventing weight loss and nutritional deficits from the malabsorption that can occur from things passing through too quickly without being absorbed. Like we did mention earlier this semester, remember, keep in mind that the primary role of the small intestine is to absorb nutrients. So if things are passing through the small intestine too quickly, the person will not absorb nutrients, and he'll be at risk for nutritional deficits and malabsorption and electrolyte deficits. And the main role of the large intestine, the colon, is to absorb water. So if things are passing through the colon too quickly, he's at an increased risk of dehydration. As far as causes of dehydration, as far as causes of diarrhea, acute diarrhea could be caused by anything that's irritating the digestive tract. It could be bacteria, viruses, it could be drugs. It could also be protozoa, or it could be nutritional factors. As far as chronic diarrhea, again, diarrhea that's been there for long term, at least 3 to 4 weeks, producing chronic conditions, chronic problems. It could be tumors, it could be diabetes, Addison's disease, hyperthyroid, some of our adrenal disorders, irritable bowel syndrome, AIDS. As far as treating diarrhea, we're going to give anti-diarrheals, and these fall into different categories. The first one that we're going to talk about are the adsorbents, which are used to treat milder cases of diarrhea. Again, adsorption is similar to absorption, like I mentioned earlier, but adsorption involves a chemical binding and preventing the absorption of something from occurring. So what the adsorbents do is they coat the walls of the digestive tract, and what they do is they help to bind to whatever that causative agent is that's causing the irritation of the digestive tract. They bind to the toxin, they bind to the drug, they bind to the bacteria, and allow it to just pass through and be eliminated without being absorbed and causing problems. Perfect examples here is Pepto-Bismol, bismuth subsalicylate, and again, salicylate means it's a form of aspirin. Keep that in mind. We'll come back to that and talk about that a little bit later. Like we mentioned earlier when we talked about aspirins and NSAIDs, lots of medications over the counter can contain aspirin in them. So it's important to do patient education with patients so they understand that what you're taking over the counter may actually contain aspirin and could lead to other problems. Activated charcoal, we mentioned earlier also, is an adsorbent. Activated charcoal binds to the toxin that the person took to keep it from being absorbed. It allows it to pass through and eliminate it from the body without being absorbed. And then other ones that we actually talked about earlier, some of the anion exchange resins, like the Colstead, that can be used for hyperlipidemia. As far as adverse effects, the increased bleeding time, that could result, again, as a as a result of the salicylate, the Pepto-Bismol. Too much aspirin from the salicylate can increase the bleeding time. Constipation, dark stools, confusion. Tinnitus, again, is a classic hallmark sign of aspirin toxicity. So from taking too much Pepto-Bismol, too much salicylate, too much aspirin, it can lead to tinnitus, as well as the increased bleeding time. Other side effects include a metallic taste and blue tongue, blue gums, blue mucous membranes in the mouth. As far as interactions, again, decreased absorption of many other drugs. So you want to make sure that you take these, about 2 hours separated from any other drugs that the person is on. They will affect the absorption of other things. Coumadin, warfarin, already talked about that. Binding to vitamin K can cause the elimination of vitamin K, which would increase the toxic effects of Coumadin, as well as if the person is taking specifically Pepto-Bismol, that could increase the salicylate level, which would have an additive effect with the Coumadin that the person is taking and have an increased risk of bleeding. Anti-motility drugs would be the next category that we're going to talk about. These are used for a little bit more severe cases of diarrhea. Two types of anti-motility drugs, basically things to slow down the passage through the digestive tract to allow things to be absorbed without passing through too quickly. And these are anticholinergics, which we talked about earlier, and opiates, which we talked about earlier this semester. The first one we'll talk about will be anticholinergics. Again, slow the peristalsis. Again, by kind of mimicking the effects of the sympathetic nervous system, slowing peristalsis down. Anticholinergics also have a drying effect, like we talked about earlier this semester. Because of mimicking the sympathetic nervous system, they dry up secretions, which can help to reduce some of those gastric secretions that are causing the problems with diarrhea. They may be used in combination with the adsorbents or with opiates, which we'll talk about in a minute. An example here is belladonna alkaloids. Belladonna is an opiate. Adverse effects, again, because the anticholinergics, we can end up with things like urinary retention, impotence, dry skin, flushing, blurred vision, headache, dizziness, confusion, anxiety, drowsiness, confusion, hypotension, bradycardia, specifically with the opiates. The second category then is, in fact, the opiates, which again decrease bowel motility. That is a very common side effect of opiates, like we talked about when we talked about pain medications. The opiates also have a secondary effect for treating diarrhea, not just by slowing down the motility, but also helping to reduce some of the pain from all those rectal spasms, from the increased peristalsis causing the cramping and the pain. Again, examples here, codeine, diphenoxylate, loperamide. These ones are available over the counter. And as far as adverse effects, again, things that we talked about already that should be obvious to you: drowsiness, dizziness, lethargy, constipation, respiratory depression, hypotension, urinary retention, flushing. Okay. The next category are probiotics. These are used specifically to treat antibiotic-induced diarrhea. Like we talked about last week with the antibiotics, one of the problems of taking antibiotics, broad-spectrum antibiotics, numerous antibiotics, is those antibiotics kill the normal flora that normally live in the gut that aid with digestion by eliminating and killing off all of those good bacteria. It affects digestion, and as a result, diarrhea often occurs. So the probiotics can be used to counteract the effects of the antibiotics by replacing some of that normal flora that normally lives in the gut to help with digestion, to restore normal digestion. These are basically bacterial cultures that normally live in the gut. An example of a medication is lactobacillus acidophilus that you will give as a medication, probiotic to try to counteract the diarrhea from antibiotics. But basically, these are also available, basically diet. Anything that has fermented dairy products in it, yogurt, cottage cheese, sour cream, buttermilk, any of those things can be used effectively to try to counteract the effects of antibiotic-induced diarrhea. As far as nursing implications, again, getting a history of the bowel patterns of the person, recent changes in their bowel pattern. Do not give the bismuth subsalicylate, which again is a form of aspirin. So we worry about the bleeding tendencies with that. Like we already talked about, we worry about the additive effects of that with warfarin Coumadin. But in addition to that, like we talked about when we talked about aspirin, is don't give that to children or teenagers because of the increased risk of Reye syndrome as well. Use the adsorbents carefully in older adults, those who have a decreased bleeding time, because again, what can happen is they can bind to vitamin K and allow vitamin K to be eliminated, and the person could be at an increased risk of bleeding. Do not administer anticholinergics to patients who have glaucoma. As we talked about with anticholinergics, when we talked about the adrenergic system, what those medications do is they cause dilation of the pupil, which would increase the intraocular pressure. So those would be avoided in patients who have glaucoma. Also avoid those in patients who have GI obstruction, myasthenia gravis, paralytic ileus, toxic megacolon. We want to make sure that we're assessing fluid volume status in patients, and then monitoring for the therapeutic effects. Let me take a drink. Okay, next, constipation, which again, I think we all understand what constipation is. It's an infrequent or difficult passage of the feces through the digestive tract. It's a symptom. It's not a disease in and of itself. It's a sign that something else is going wrong, some underlying condition, which may be able to be treated. As far as treatment, options for constipation, treatment options could be surgical or non-surgical. Non-surgical interventions could include dietary, which would be increasing fiber, but remember with fiber, like we talked about before, whenever you increase fiber, you also have to increase water at the same time. Fiber basically attracts water, it draws water to it, and so you don't want to give somebody fiber supplements without also giving them water, or what's going to happen is you're going to give them fiber supplements. The fiber supplements is going to get in the digestive tract, it's going to draw water to it, and it's going to make the stools even harder. So you want to always make sure that you increase fiber and fluids at the same time. Both are important. As far as behavioral, number one intervention to counteract constipation, we mentioned before, is increasing physical activity. Physical activity is the best thing that the person can do to restore natural peristalsis through the gut. So try to get that person up and active and moving as much as possible. As far as pharmacological treatment, this is where we're going to talk about using laxatives and stool softeners. But it's important to understand that laxatives are one of the most overused and misused over-the-counter medications that people do use. And the problem is it can lead to dependence. The digestive tract, the gut, the peristalsis can actually become so dependent on the person taking laxatives and stimulants to stimulate the peristalsis that it shuts down, it slows down. And then the problem is the person actually needs to have a laxative in order to have peristalsis. So it's important to educate the person as far as taking over-the-counter laxatives, not to take laxatives unless you need them. Don't take them on a daily basis. And this is actually a problem in a lot of our older adults who are so worried about constipation that they take a laxative on a daily basis. Laxatives are only to be used as needed, which is in fact different from stool softeners that we'll talk about. Stool softeners can be taken on a daily basis, but laxatives cannot. So make sure you understand that. As far as laxatives, there's different types of laxatives. The first one we'll talk about is bulk forming laxatives. Basically, mechanism of action: having a lot of fiber absorbs water, like I already mentioned earlier, to increase the bulk. What that does is it helps to kind of soften the stool that's already in the bowel. It helps to distend the bowel, and basically by distending the bowel, then it initiates the reflex peristalsis to push things through. Examples of bulk forming laxatives are Metamucil and Citracel. As far as those medications and patient teaching, make sure that you educate the person that after I mix them up, basically we put the granules, the fiber, into 8 ounces of solution, and 8 ounces of juice, 8 ounces of water, and we stir it up. But we want to make sure that we educate the person to take those as soon as we stir them. What happens if we let it sit too long? It actually starts to congeal and turn into a gel, a solid, and then the person can actually have a lot of difficulty swallowing it, and it could lead to choking hazard. So make sure that people who are taking Metamucil and Citracel, make sure you educate them to take it as soon as they're finished stirring it. As far as indications, they can be used for acute and chronic constipation, also used for irritable bowel syndrome and diverticulosis. It's important to understand diverticulosis. We can increase fiber and use bulk forming laxatives to manage diverticulosis, which is the outpouching from the weakening of the lining, the walls of the digestive tract. But we do not use bulk forming laxatives. We do not use lots of fiber to treat diverticulitis, which is an inflammation of one of those outpouchings. We actually put the person on a very low fiber diet whenever they have an inflammation of those outpouches. So bulk forming laxatives can be used for diverticulosis, not diverticulitis. As far as adverse effects, impaction, and again, especially if they're taking the bulk forming laxative without sufficient water, that's where the danger is. It can lead to constipation and impaction. It can also lead to fluid overload, electrolyte imbalances, or it could lead to an esophageal blockage. Again, if the person is not taking it with enough water, or if he's trying to drink and take his bulk forming laxative without or after letting it sit too long. The emollients is the next category of laxatives, which is basically your stool softeners, your lubricants. As far as mechanism of action, they lower the surface tension of the GI fluids. They help to lubricate and soften what's in there. They promote more water and fat in the stool to lubricate the fecal material, the intestinal walls, to allow passage a lot easier. As far as examples, for stool softeners, the prototypical one here is Colace, your docusate salts, docusate sodium, is a stool softener. Again, stool softeners can be used on a daily basis, whereas the other ones can't. Keep that in mind. It can lead to dependence. And as far as lubricants, mineral oil basically helps to lubricate the stool, helps to lubricate the intestinal wall to allow easy passage. And again, these can be used on a routine basis. They can be used for both acute and chronic constipation, fecal impaction, by again promoting the absorption of water into the intestines, by lubricating and softening the stool that's already in there. They can be really helpful for fecal impactions and facilitation of bowel movements. As far as adverse effects, there can be a delayed absorption of vitamins, especially with the use of mineral oil. It can lead to a decreased absorption of the fat-soluble vitamins, so keep that in mind. Can lead to electrolyte imbalances, skin rashes. As far as the hyperosmotic laxatives, again, the word itself kind of tells you what's going on. We're creating a hypertonic environment. The site of action for these medications is the large intestines. So by creating a hypertonic environment, you're promoting the osmosis, you're promoting the movement of water into the digestive tract, which again results in a bowel distension, increased peristalsis, and then evacuation of what's in there. Examples are polyethylene glycol, sorbitol, glycerin, lactulose. The polyethylene glycol, the PEG, the name that you guys probably are familiar with is Go Lightly. You guys probably have given, or at least are aware of, the Go Lightly prep that's pretty frequently given before procedures to make sure that the person eliminates everything that's in his digestive tract, so that the doctor can have easy visualization of what's in there whenever he goes in to do a colonoscopy procedure. Go Lightly basically causes bowel elimination within 4 hours of taking it, so it helps to completely eliminate what's in the bowels. Lactulose, as it says on the slide there, and I put this in red for you to make sure you understand this, is also very frequently used to reduce serum ammonia levels. So when we have a liver patient who's building up ammonia levels in his body, we do frequently give lactulose to help to bring down the ammonia levels. Lactulose is basically just a synthetic derivative of lactulose, which basically passes into the large intestine, and then by having that sugar, that lactulose, in the intestine, the bacteria that live in the colon digest the lactulose. They create a hyperosmotic environment, and that drug-induced acidic environment also reduces the blood ammonia level by converting ammonia into ammonium. And ammonium is basically a water-soluble cation that cannot be reabsorbed, and so it allows the ammonium to be eliminated, thus getting rid of ammonia levels in the body. So I just want you to understand what's in red there, that the lactulose very frequently is used to reduce ammonia levels in liver patients. As far as indications, chronic constipation, and then most frequently for diagnostic and surgical preps. Adverse effects, abdominal bloating, electrolyte imbalances. Make sure that you're assessing electrolyte levels before you're using any of the hyperosmotic laxatives. Make sure you look at electrolyte levels, and it can also cause rectal irritation. As far as saline as a laxative, again, saline can be used because it is an increased osmotic pressure medication. It creates a hypertonic environment, drawing water to it. So as a result, it draws water into the intestinal tract, causing distension, causing more water to help to soften what's in there, and increase peristalsis and evacuation. Examples of saline laxatives are magnesium hydroxide, milk of magnesia, and magnesium citrate. And again, remember, magnesium itself is a digestive tract smooth muscle stimulant, so it actually helps to stimulate peristalsis as well, the magnesium in there. Basically, your saline laxatives like milk of magnesia produce a watery stool within about 3 to 6 hours after taking. As far as adverse effects, these have magnesium in them, so when the person has renal insufficiency, like I mentioned earlier, use with a lot of caution. Taking milk of magnesia or mag citrate with renal insufficiency, with kidney disease, can lead to hypermagnesemia. Other adverse effects: cramping, diarrhea, electrolyte imbalances, and then increased thirst as a result of losing too much fluid through diarrhea and producing basically dehydration. The last category there is the stimulant laxatives. These are the most likely of all the laxatives to produce dependence. So make sure we understand that. As far as mechanism of action, the action with our stimulant laxatives is directly proportional to the dosage that's given. So the more that is taken, the more stimulation of peristalsis that results. But as far as mechanism of action, these produce increased peristalsis by increased intestinal nerve stimulation. Examples are Senokot and Dulcolax. All the other stimulant medication laxatives have been removed from the market, but you will see Dulcolax and Senokot. Indications, acute constipations. Again, you notice that chronic is not on that list. They really should not be taken on a long-term basis. These are the most likely to produce dependence, so only acute shows up on that list. And then also for diagnostic and surgical preps to eliminate what is in the digestive tract so the doctor can see what he needs to see when he goes in there for a colonoscopic procedure. Adverse effects, malabsorption, irritation, electrolyte imbalances, irritation. We talked about all these things. All right. Next, peripherally acting opioid antagonists, basically treatment of constipation related directly to opioid use. Like we talked about when we talked about pain medications, constipation is a very frequent side effect, adverse effect of taking long-term opioids. So medications have been developed in order to counteract the constipation that sets in as a result of long-term opioid use, very frequently for our cancer patients. Make sure that you're assessing bowel function whenever the person is taking opioids. Now, as far as examples of these medications, the Relistor, the Entereg. The Relistor is approved only for hospice patients who are taking opioids. So this is our, opioid-induced constipation for our cancer patients. And then the Entereg basically helps to increase recovery time for patients who've had a bowel resection surgery. The Entereg is only given to patients on an inpatient basis. The patient must be hospitalized, must be registered to receive Entereg. Entereg is not given on an outpatient basis, on an outpatient usage. And again, this is given for patients who've had bowel resection therapy. As far as nursing implications for laxatives, all laxatives can cause electrolyte imbalances. Mention that, make sure you understand that. A healthy high fiber and increased fluid intake should be encouraged. As an alternate to laxative use, increase activity as much as possible. Like I already mentioned, that's the most natural way to increase natural peristalsis to try to counteract constipation. Long-term use of laxatives can result in decreased bowel tone, can lead to dependency. I already mentioned that. Patients should take all laxatives with at least 6 to 8 ounces of water. Again, the more water, the better. Monitor the patient for severe abdominal pain, muscle weakness, cramps, dizziness. Those things could all indicate possible fluid and electrolyte imbalances. The last thing here to talk about real quick is irritable bowel syndrome, a condition that affects women much more than men. It's a chronic intestinal discomfort characterized by cramps, diarrhea, constipation, usually as a result of stress, irritating foods, taking over-the-counter laxatives, anti-diarrheal drugs. Can be used for irritable bowel syndrome. Zalnorm, Amitiza. You'll see these ones used pretty frequently. Amitiza has actually been taken off the market except for emergency uses, although you will see it being given in the hospitals. Elocitron, Latronics is the last one on the list there, which is basically an SSRA drug, which we'll talk about later as well. A selective serotonin reuptake antagonist. Basically, if the Latronics is ineffective after 4 weeks, then it should be discontinued. And also, it's important to know that Latronics should be discontinued immediately if constipation or signs and symptoms of ischemic colitis start to occur, things like bloody bowel movements, severe abdominal pain and cramping, then the Latronics should be discontinued immediately. As far as nursing implications, again, make sure you get a good assessment, follow the administration guidelines, monitor the therapeutic response, the obvious things. Last category to talk about real quick, the last chapter to talk about is antiemetic and anti-nausea drugs. Definitions, I think we know what nausea is. Basically, God put this sense in your body whenever something is irritating my digestive tract, whenever something is irritating me, we've got this system in place to purge it, to get rid of it. And so I get this sense of nausea, an unpleasant feeling that I need to purge my system. Emesis, or vomiting, is the forcible purging of the gastric system, and occasionally the intestinal, not just the stomach, but sometimes the intestinal contents. But there's some kind of stimuli that induces the vomiting. Again, it could be an unpleasant taste, could be an odor, a sight, some kind of GI irritation, a drug that I've taken that's irritating my digestive tract. But God put this purging system in place so I can get that out of there because it's irritating to my digestive tract. Antiemetic drugs are drugs that are used to relieve nausea and vomiting. Vomiting occurs as a result of the vomiting center and the chemoreceptor trigger zone. These two things are both located in the medulla oblongata. Basically, the vomiting center is an area in the oblongata, medulla oblongata, responsible for initiating vomiting. It's initiated by the chemoreceptor trigger zone, which receives input from the body, communicates to the vomiting center that the body needs to purge something. It triggers this sense of nausea, which leads to emesis, vomiting. It's mediated by neurotransmitters that stimulate those chemoreceptor trigger zones that then go on to the vomiting center. Some of those neurotransmitters are acetylcholine, dopamine, serotonin, histamine, prostaglandin, substance P, which again, once they stimulate the chemoreceptor trigger zone, it then stimulates the vomiting center to cause vomiting. Types of nausea and vomiting. General nausea and vomiting is what you and I are familiar with. Something irritates my digestive tract and I feel nauseated and I vomit. But then we also have a couple specific ones. We have chemotherapy-induced vomiting and we have postoperative vomiting. These are more intense. They have a lot more intense symptoms, and as a result, they are treated a lot more aggressively. As far as antiemetics and anti-nausea drugs, they all work at some site of that vomiting pathway that I already mentioned, and they're all listed there. We're going to talk briefly about each of these. When drugs from more than one category are combined, the overall effectiveness is increased because now we're working on more than one of those pathways. More than one of those pathways end up being blocked to try to have a synergistic effect and have a compounded and exaggerated effect in how well it treats the nausea and the vomiting. As far as overall antiemetic and anti-nausea drug mechanism of action, many different mechanisms of action, but again, most of them work by blocking something in that vomiting pathway, and that is listed there. Mechanism of action for anticholinergic drugs. These ones, make sure you understand, used with caution in older adults. They can cause psychosis, agitation, and then obviously all the anticholinergic effects that we've talked about several times throughout this semester. Anticholinergic means that they're blocking acetylcholine. And that can be helpful by blocking the transmission of nauseating stimuli, the acetylcholine, on that the chemoreceptor trigger zone. Example here is scopolamine. Scopolamine very frequently is usually used as an anticholinergic to actually help to dry up secretions. Transdermal can be a little patch that's applied behind the ear. It's also available orally, injectably. But again, because it's anticholinergic, one thing to make sure that you remember that I mentioned just a few minutes ago with anticholinergic medications is scopolamine is contraindicated for patients who have glaucoma. because those anticholinergics, again, mimic the effects of the sympathetic nervous system, and one of the effects of the sympathetic nervous system is pupil dilation, which would increase intraocular pressure. So anticholinergics are contraindicated for patients who have glaucoma. Next category of medications is the antihistamines, which we've talked about previously this semester. Again, use these medications with caution in older adults. Again, may cause psychosis, agitation. Antihistamines are blocking histamine, which is another of those transmitter that falls in that vomiting pathway. What it does is it prevents the cholinergic stimulation in the vestibular and the reticular areas, preventing nausea, vomiting, very similar to the anticholinergics. Again, contraindicated with patients with glaucoma for the same exact reasons. Most frequently, you're going to see the antihistamines used to treat motion sickness, allergy symptoms, sedation, but they do have some indication here for nausea and vomiting, so they're talked about. But Dramamine, Benadryl, Anavert, which is usually used to treat dizziness, vertigo. And then another one here is hydroxyzine Vistaril, which we didn't talk about before. Vistaril is available both orally and intramuscularly, but never subcutaneously or intravenously. It can lead to tissue necrosis, so make sure you understand that. Next category is anti-dopaminergic drugs. Again, dopamine is another of those mediators of nausea and vomiting. So these medications block dopamine receptors in the chemoreceptor trigger zone. They also have anticholinergic properties, and they also have anticholinergic signs and symptoms like we talked about before. Most frequently, these are not most frequently, but in addition to treating nausea and vomiting, these anti-dopaminergic drugs can also be used for psychotic disorders and also for intractable hiccups that are difficult to manage, difficult to treat. And I have that in red there for you so it stands out. Examples and very common ones are compazine and Phenergan. Droperidol, we're going to talk about later also. Use these medications with caution when the patient has dehydration or any electrolyte imbalances. These medications also may cause a lot of extrapyramidal effects, some abnormal muscle movements that can set in as a result. So make sure you understand that. Phenergan, promethazine, is available orally and intramuscularly. You will see it both routes pretty frequently. However, Phenergan, if given IV, it can be ordered IV, but if given IV, make sure it's diluted. Make sure that you're injecting it in the Y port that's furthest away from the body. Make sure that you're infusing it very slowly. If the IV infusion produces any pain at the injection site, discontinue the IV infusion immediately. What can happen is if that IV infusion infuses too quickly, or if the IV infusion infiltrates in any way, it can cause a lot of severe tissue damage, which can actually be so severe that it can lead to amputation of the extremity. And for that same reason, we do not give Phenergan subcutaneously. When given appropriately, orally and intramuscularly, sedation is a common side effect of Phenergan, so that's not unexpected. The next category of medication that we're going to talk about for nausea and vomiting is neurokinin receptor antagonists. These are your prepidents. If you look down below at the examples, aprepitant and fosaprepitant, these generics end in prepitant, so you can recognize them. What these ones do is they inhibit substance P receptors in the brain, using in conjunction with serotonin blockers, glucocorticoids. Very frequently, most frequently, these ones are used for the chemotherapy-induced emesis, because again of the increased symptoms with chemotherapy induced nausea, vomiting. As far as other things to know with aprepitant, fosaprepitant, AMED, there's an increased metabolism of coumanin, so make sure that you're monitoring the INR on patients who are taking EMED along with coumanin, and there's a decreased effectiveness with oral contraceptives, so there's an increased risk of unplanned and unwanted pregnancy. Kinetic drugs is the next category to talk about. These block dopamine receptors in the CTZ. Similar to what we talked about earlier, they also stimulate peristalsis in the GI tract. Most frequently, these are used to try to increase GI motility. Can be used to treat GERD, delayed gastric emptying, but again, very frequently used to increase gastric motility. The example here is metoclopramide, Reglan. Make sure you understand long-term use. You can put a star next to this, the very bottom bullet point there. Long-term use of Reglan can lead to irreversible tardive dyskinesia, and keyword there is irreversible. So Reglan should not be used on a routine long-term chronic use. It's also contraindicated for patients who have seizure disorders, and because these prokinetic drugs like Reglan, metoclopramide, is very frequently used to increase GI motility. As we talked about earlier, these would be contraindicated for patients who have bowel obstructions. You don't want to give somebody with a bowel obstruction something to increase peristalsis, which could make the symptoms of bowel obstruction even worse and lead to something like a toxic megacolon. Also, there's a decreased effectiveness when taken with an opioid or an anticholinergics, because again, the opioids, the anticholinergics, like I mentioned earlier, decrease peristalsis. So these two medications would be antagonistic of each other. They would work against each other. The next category of drugs is the serotonin blockers. If you look down below, these are our cetrons. They all end in cetron. The most common one there is ondansetron, your Zofran. You're going to see this given pretty frequently. It is, in fact, the prototypical drug of this class. What these medications do is they block serotonin receptors in the GI tract, the CTZ, and the vomiting center. These are used for nausea and vomiting. Specifically, they were designed for patients receiving chemotherapy and post-op nausea and vomiting because, again, those patients have increased symptoms of nausea, vomiting, and so it needs to be treated a little bit more aggressively. So you will see the serotonin blockers used for patients who have more severe nausea and vomiting. And like I said, Zofran is used pretty frequently. Now at the same time, Anzimet used to be used frequently for severe nausea, vomiting, Dilasetron. However, it's no longer recommended by the FDA because it leads to potentially life-threatening dysrhythmias. And incidentally, the FDA also has recently issued the same warning for Zofran, ondansetron, which we do give very frequently, that there is an increased risk of cardiac dysrhythmias and there's an increased risk of dehydration. Make sure you're assessing for dehydration. Next category. THC, tetrahydrocannabinoids. As the name sounds, it is the major psychoactive substance, THC, in cannabis, marijuana. But the reason it can be used to treat nausea, vomiting, it has an inhibitory effect on the reticular formation, which we talked about a couple weeks ago. I told you that reticular formation, that reticular activating system, kind of serves as the secretary sitting at the front door of the desk, sitting at the main desk of the brain, that it's responsible for kind of receiving the input and telling that input where in the brain to go to get interpreted. So marijuana, THC, has an inhibitory effect on that reticular formation and then the thalamus, the cerebral cortex, in order to alter the body's perception of what's going on around it. Again, if I were to take that receptionist sitting at the front door of the brain and I would send her on her lunch break, then stimuli that's coming to the reticular formation from the body don't necessarily know where to go. They don't know how to be interpreted because she's not there to tell it where to go. So it kind of inhibits the stimuli that's coming into it. So THC helps to alter the body's perceptions, which in response can help to relieve the nausea and vomiting signals that are coming into the central nervous system. So the example here is dronabinol, which is Marinol. You will give Marinol occasionally for use with anti-nausea, anti-vomiting, but most frequently you're probably going to see Marinol prescribed and used as an appetite stimulant to treat patients who have a poor appetite. Miscellaneous anti-nausea drugs. Emetrol is basically a mint-flavored oral solution. Works by direct action on the walls of the GI tract to help reduce some of the cramping. However, it's mild. It's not sufficient to treat any of the more severe nausea symptoms. Frequently, it is used off-label for just the treatment of morning sickness. Because again, somebody who's pregnant, we don't want to give them, any powerful medications that might be, counterintuitive for somebody who's pregnant. So we want to give them something more mild, more natural. So Emetrol is effective for those type of patients, but not for somebody who has severe nausea and vomiting. Similarly, ginger. I just throw this in there to make sure you understand. Natural herbal remedy, people will take ginger as well as the mint, like I just mentioned, to help treat some of the nausea and the vomiting. But again, just because it's natural and herbal doesn't necessarily mean safe. It does have an increased risk of bleeding when used with anticoagulants, like we mentioned earlier this semester. And also ginger may increase the absorption of all oral medications. The word all should be there. All oral medication absorption is increased when used with ginger. And then finishing this up, nursing implications in general. Many of these drugs cause severe drowsiness, so warn patients about that. Make sure that they know not to drive or do hazardous tasks when taking these drugs. Taking antiemetics with alcohol can increase the depression of the central nervous system. Teach patients to make position changes slowly to avoid hypertensive effects. Monitor the therapeutic effects, monitor the adverse effects. All of those. If you have any further questions, as always, please email me, please come and see me. Allow me to talk through any of these concepts or give you examples that might help to eliminate any confusion you have. All right, so thank you very much, and let me know if you have any problems.